All right. So good evening and welcome to the Retina Foundation's Keeping an Eye on Innovation lecture. My name is Amy Loebner, and I am a development manager at the Retina Foundation of the Southwest. We are so pleased that over 190 guests from across the country and around the world are joining us this evening to learn more about the Retina Foundation and to hear about Dr. Weber's cutting-edge research in children with amblyopia, commonly referred to as lazy eye. We created this lecture series to bring awareness to and provide education for the public on the most up-to-date research from renowned leaders in our three core areas of research: pediatric eye conditions, inherited eye diseases, and age-related macular degeneration. I would like to share with you a brief video highlighting our innovative research at the Retina Foundation. Bear with me one moment, the slides are a little slow here. The past 18 months have challenged us in ways we never could have imagined. However, the scientists and staff at the Retina Foundation continue to persevere with one shared goal in mind: to advance our unwavering mission to prevent vision loss and restore sight through innovative research and treatment. We were able to continue to do this even during a global pandemic because of the support from you, our worldwide community. I would now like to recognize and thank Dr. and Mrs. William Hutton for their long-standing support of the Retina Foundation. Dr. Hutton is one of the founding members of the foundation, and he and his wife, Sue, graciously agreed to sponsor this lecture series in 2020 and again this year in 2021. We extend our sincere gratitude to both of you. Today, as those of you who live in Dallas already know, is North Texas Giving Day, an 18-hour online giving event designed to empower every person to give back to their community by supporting and building awareness for local nonprofit organizations. North Texas Giving Day is the largest community-wide giving event in the United States. Everyone has the opportunity to be a philanthropist, to build a stronger and more vibrant community, and we invite you to join us in supporting our mission today. Please visit our North Texas Giving Day page by scanning the QR code on the screen. Thank you in advance for your generosity. I will now turn the evening over to Dr. Krista Kelly, Director of the Vision and Neurodevelopment Laboratory at the Retina Foundation, to introduce our featured speaker tonight, Dr. Ann Weber. Dr. Kelly?
Hi, Amy, thank you very much. So it looks like we have a really big crowd here tonight, which is fantastic. I'm really excited to introduce Dr. Ann Weber for tonight's Keeping an Eye on Innovation lecture. And I'm really glad that she could join us from halfway across the world in Australia. I believe it is morning there. So Dr. Weber has an impressive career in optometry, spanning private practice, teaching, and clinical research. She's an optometrist with a Master of Science in Physiological Optics from the University of Houston, and she has a PhD from Queensland University of Technology. After receiving her PhD, she started her own practice, and she is also an adjunct associate professor at both the Queensland University of Technology and the University of New South Wales. So on top of all of her clinical and regulatory service that she does, Dr. Weber somehow finds the time to also conduct cutting-edge research that informs clinical practice and focuses on the functional impact of amblyopia, binocular perception, and amblyopia treatments, which is what we'll hear all about tonight. In fact, it's her work on the impact of amblyopia on children's everyday lives that has fueled my own interest in investigating motor impairments in children that have pediatric eye conditions. So I think that Dr. Weber must have loved Texas so much after getting her master's in Houston, because she keeps coming back to visit us. She has visited multiple times with Dr. Birch, Dr. Eileen Birch and I, to work on collaborative research projects, including developing new tests of binocular function for children and evaluating how amblyopia affects children's motor skills and their self-perception. Currently, she is collaborating with the Retina Foundation on a clinical trial to evaluate a new treatment for amblyopia for preschool children. So although we haven't really seen her in a while, we're looking forward to a time when Dr. Weber can visit us again in person. But until then, we'll enjoy seeing her virtually while she tells us all about amblyopia, the real world impact of, and emerging treatments for lazy eye. Dr. Weber?
Okay. Now, good morning and thank you. Good morning, good evening, and thank you very much for that kind introduction. Krista, can you give me the thumbs up that you can see my presentation screen? Fantastic, thank you. Thank you very much for the kind invitation. It really is an honour to be part of this seminar series, and I'd like to really recognise and convey how much I value the collaborations that we have enjoyed over many years, and I look forward to those continuing. So before I start, I would like to just make a note of my affiliations, which Krista has alluded to. So I have positions, academic positions with the University of Queensland University of Technology, University of New South Wales. I also work with the Department of Ophthalmology at the Children's Hospital in Brisbane. And today I'm coming to you from my home in Bulimba, which is sort of in this bend of the river in Brisbane. Now, Bulimba means home of the magpie lark in the language of the Turrbal people, which are the traditional custodians of lands that I'm coming to you from today. And I would like to pay my respects to their elders, past, present, and emerging. So first of all, what is amblyopia? Well, amblyopia is poor vision from abnormal vision development. We need to think about it. It's a little bit different to perhaps some of the topics that you've had in some of your other series, in that it's not a disease. It really is something where there's been an impediment to how the typical visual pathway would develop. It's the most common cause of visual loss in children. And it affects between 3 to 5% of children, so it's really common. And this sort of persistence of vision loss means that even into our middle years, it continues to sit there as the most common cause of reduced loss, so poor vision even in our adults in their 40s and 50s. So it's an important condition to recognise and to treat effectively. Now, most commonly, we think of amblyopia as being a unilateral condition, so a lazy eye, but it can be bilateral. And certainly emerging studies and the work that's been conducted by Dr. Birch and Krista are very much showing the evidence of how amblyopia impacts the fellow eye, so the eye that we always considered to be a normal eye in children with amblyopia. So it does impart a lifelong loss of vision if it's not identified and treated early. So the vision development of the typical visual pathway is hampered either by something in the anterior aspect of the visual pathway. Now that may be retinal blur from uncorrected refractive error, or it can be ocular misalignment, so strabismus. And if those conditions are present early in life, then the typical development of vision just doesn't happen. So what is our sort of typical optimum vision development? So for optimum vision, we need sensory fusion of concordant visual information. And so basically we have images that fall on the retina. And for good vision, you would want the information from each eye to be combined. So the sensory component is you have cortical combination of signals from each eye, and that occurs in the primary visual cortex that's at the occipital lobe of the back of the brain. We also have a motor component, so we have 6 extraocular muscles that work in tandem pairs to, align the two eyes so that they work together as a team. So the purpose of that motor component is to bring the image of an object of regard onto the fovea and keep it there, and position the two eyes so that the fovea is aligned at all times, and that's for the maintenance of clear single binocular vision. So these two components, the sensory and the motor components of vision, depend upon each other to end up with our clear single binocular vision. So clear single binocular vision, which is necessary for normal vision development, requires a sensory fusion capacity. So we need binocularly responsive cells in our visual cortex. We need clear balanced retinal images. So those images need to be similar so that the vision center can combine them. So it is important that any differences in clarity between the two eyes gets corrected for that vision development to occur to its best capability. We need accurate and flexible accommodation, so we want clear vision at all working distances, and we want accurate alignment of the visual axes at different fixation distances, so going all the way out to infinity vision and up to close. So these things are all necessary for that optimum visual development to occur. So when we think about, well, what causes amblyopia, it's a condition that's interfering with that binocular sensory fusion during the critical period of neurodevelopment. So this sort of concept of critical periods is really important too when we're trying to understand amblyopia. So what we need to remember is that the visual neurophysiology between the eye and the visual cortex isn't fully developed at birth. And that normal vision requires cortical integration of corresponding retinal information. Now, that normal visual development won't proceed if there's a condition that is interfering with sensory fusion. So when we think about vision for a newborn, it is quite achromatic. There's not as much, our color perception is not fully developed. We don't have the type of size and packing of photoreceptors that's required for high level, high resolution vision. But that does develop quite rapidly. And, by 3 months of age, we're starting to get color coming in. And by 6 months of age, really starting to get quite, acute vision. But if there's something that's present, particularly in those early years, then the normal visual development will be hampered. So what are those things that can interfere? Well, the main ones are a difference in refractive error between the two eyes. So that's anisometropia. So with that, you will have dissimilar retinal images due to the uncorrected, to the blur that's present with the uncorrected refractive error. Or we could have strabismus, so we talk about strabismic amblyopia, and that's where we've got ocular misalignment, so we have impaired binocular combination of the retinal signals. And if that occurs, and this one's really critical, so if we have constant strabismus early in life, sort of particularly around that 3 to 6 months of age, then the opportunity to develop binocular capacity is quite poor. And the third one, which is rarer, is that we can have deprivation. So you can have something like a cataract or a corneal opacity, and if that's enough to cause blur, then and particularly if that's in one eye, then that can be very degrading to how vision develops. So here we've got a little cataract in the eye. And these retinal photos sort of show the impact of that blur on the retina, whereas the retina of the fellow eye is quite clear because its lens is clear. So, by the time the visual center is trying to combine the information from these two eyes, it isn't able to do it capably. And so the capacity for vision to develop in this young visual system is impeded. So So there is a pathophysiology that's associated with then amblyopia, and really we know very much that it is in the visual cortex. But whilst really from work that happened in the later half of last century, we know that there are structural changes in the striate cortex, but then more recent studies have shown us that there are structural changes that occur at the lateral geniculate body, and which is sort of the first sort of switching station where the synapses occur from the optic nerve before they pass on. And whilst our clinical exam generally shows that the eye looks quite healthy, so the retina looks healthy to our general clinical exam, there are now better tools that, including tests such as ocular coherence tomography, that are showing us that in fact there are microscopic anatomical and structural changes that can occur in the retina. So the retina can be a little bit thickened, and with the sort of the most recent OCT machines, we're seeing that there are changes in the avascular zone. So whilst we've sort of typically really thought about amblyopia as being higher up the visual pathway, there is certainly now evidence that amblyopia does have this downstream effect. I guess what we don't really know is what is cause and effect. So there's still lots of questions to be answered there, but there is definite evidence that we've got structural and functional damage that's occurring in the LGN and in the striate cortex, and so we have atrophy of connection, loss of cross-linking between the connections, and loss of laterality of connections that is occurring. So for our clinical diagnosis, as Krista pointed out, I've spent the majority of my my practicing life in the consulting room, and one of the things that we're looking for is that diagnosis of amblyopia, and our clean diagnosis is if we have reduced visual acuity in one or both eyes, but typically it's one eye where you've got a 2-line reduction in best ability to be measured visual acuity. That's there despite having corrected any underlying refractive error. So I'm sure we're all very familiar with the blur that may come from being short-sighted and not having your glasses on. But with amblyopia, it's, well, we're putting the glasses on, we're correcting the refractive error, but the visual system is still not seeing well. So it's that loss in best corrected visual acuity, and if it's a 2-line decrement, then that meets our kind of cutoff for a diagnosis of amblyopia. So in children who are too young to be able to give us feedback on what they can see, we will rely on our objective observations of their capacity to engage with each eye. So we look to see whether there's a unilateral fixation preference for one eye over the other, despite some full correction of their refractive error. And there are some little tests that we can do clinically where we're looking for reflexes that would suggest they've got equal capacity to engage with each eye, or have got the capacity to fuse the information from both eyes. So as well as having poorer visual acuity, we need to know that there is actually some recognised factor that would be associated with amblyopia. So we need to have evidence of significant refractive error, or evidence of the type of strabismus that generally causes amblyopia, or evidence of, say, a cataract or some sort of corneal opacity. So something that is likely to have impeded that normal vision development. We do look for signs of suppression, so ignoring of one visual pathway, and with that suppression we will get reduced depth perception. So there are clinical tests that guide us to whether or not the child can see in 3D. And importantly, amblyopia is also a diagnosis of exclusion, so we need to have no signs of any other ocular pathology that might be explaining this vision loss. And this can be one of the real challenges of pediatric optometry, is that we can often sort of, jump to that conclusion that we've got a child with amblyopia because it's the most common cause of visual loss. But we also, as clinicians, need to recognise that whilst rare, there can be sinister pathology that does exist in kids as well. So we want to make sure that we're not missing something like, a brain tumour that may be the cause of reduced vision as well. So we do need to look sort of for a pattern within these clinical findings before we come to this clinical diagnosis that we have amblyopia. So what is the real world impact of amblyopia? And this is really, what I've been asked to speak on. So I'll sort of follow through sequentially here, sort of talking a little bit more about some of the impacts that amblyopia has on various vision elements. So there's a whole range of aspects that actually make up the visual world that we live in. Also, we'll talk about some of the studies that have looked at functional task proficiency and the psychosocial impact. So the impacts on family and child that go beyond what you can see and what you can do. So if we start with impact of vision, so, I think we're all pretty familiar with that sort of typical eye chart that we see when we have our ophthalmic exams. In children, we tend to work more with shapes. So from about 3 years of age, children can be pretty good at doing a matching task where they can give us the feedback that they're able to resolve an image, an object, so we do know that amblyopia does just degrade visual acuity, so you need to have shapes or letters larger before you can see them. One of the things that's really a bit unique in amblyopic vision loss is something that's called a crowding phenomenon. So with this, you almost get like a cross degrading of vision. So if you present somebody who has amblyopia with a line of letters, they will do much worse than if you present them with a single letter or shape on its own, an isolated letter. So typically, if we're screening for amblyopia, we want to make sure that there is some sort of flanking around our object of regard, so that it is being presented in a crowded setting. And it's when we have a crowded setting that when you have amblyopia, you tend to do much worse. And that's kind of that crowding impact is I think really quite nicely been able to be demonstrated in a study that Bartlett presented in 2003, where he had adults with amblyopia view gratings. So they were looking at it, but if they looked at it with their amblyopic eye, instead of seeing just vertical stripes, they were actually seeing quite a distorted kind of image. So they would look at the grating with their amblyopic eye, and then they cover that so that they could see well enough to draw, and then they drew out what that grating actually looked like to them with their amblyopic eye. So you can see it's not just blurred, it is actually almost jittered and distorted in these sort of various drawings that are being that were made by people with amblyopia from different causes. So I think that kind of gives a bit of an idea of as to why this contour interaction or this crowding effect is a feature. It's almost like anything around it is sort of jittering and degrading the vision as well. As well as poorer acuity, people with amblyopia do have less accurate and efficient accommodation. So that ability to adjust focus from long distance to near is not quite as accurate and reliable. We have reduced contrast sensitivity. Now, contrast sensitivity is our measure of sort of how well we can resolve the light and shade in a scene. So if you've got poor contrast sensitivity, you might do very well in a high contrast, so a high black on white setting, but do less well in a low contrast. So if you think about, in a misty sort of setting, you won't do as well. We also talk about visual evoked potential, which is the potential that can be recorded from electrical activity. That's poor, and that's really an objective measure that's telling us how the visual system is impacted. And there's also altered positional sense. Now, things like vernier acuity, which is your ability to sort of judge alignment of things, is a higher up the visual pathway capability, and that is reduced. We also know that eye movement control is poorer in people with amblyopia, so their fixation stability, so how well you can just look at an object of regard and hold your eye very steady, is not quite as good. And you can also be poorer at making and initiating a fast eye movement to change your visual attention from one point to another. As well as sort of spatial information, so whether or not you can see, when you're just looking at a stable image, aspects of the object. We also have to have the ability to interpret motion within our visual world. And so there are a number of tests that have looked at how you would measure that, and how you might find whether or not a visual system is as capable as another with being able to interpret motion and movement. And two of these tests have looked at, one is global motion and another is motion defined form. So here we can look at what's sort of the lowest amount of elements moving in a particular direction do you need to have. If we've also got a little bit of random sort of movement noise around that, what's the least that you need to have to be able to judge the direction of the way things are moving. So here we can see when you've got a lot of elements sort of moving in a direction, you can easily judge which way things are going. If we introduce some random elements, so as long as you've still got a significant number moving in one direction, you can judge the global motion. So what we know with amblyopia is that they need to have more of those elements in that forward direction for you to be able to judge motion. So their ability to interpret that temporal component is reduced. Another aspect of motion capability is being able to see sort of figure ground motion as well, so seeing whether or not you can identify motion going within background motion noise is important as well. And here's an example of that, sorry. So here the task is to be able to identify the orientation of a shape based upon just the movement of the elements. So this motion detection is poorer in people with amblyopia, but importantly, it's been shown that this motion deficit is present in the fellow eye of an amblyopic visual system as well as the affected eye. So it's really showing that the overall consequence of amblyopia goes much beyond what we typically thought of maybe a generation ago, which was just, I can't see the eye chart with my one eye. So we've sort of talked a little bit about how amblyopia affects the primary affected eye and how it affects the fellow eye. But with both eyes open, what's going on? And this is a really important concept in amblyopia, is the concept of suppression. So suppression is almost then how the visual system has dealt with the hand of cards, with the cards it's been dealt with. So if you have a typical visual pathway, you will be looking at an object. The image of that will be falling on each retina. The information from both pathways then can be combined in the visual cortex. If you have strabismus, then instead of having a single image, you would have diplopia, which can be confusing. And so the response is to ignore the information coming from one visual pathway, and that the visual pathway is really just cognizant of the information coming from whichever one is the dominant eye. or if you have significant difference in retinal images between the two eyes, then again, suppression is the kind of active process of damping down the information that's coming along that visual pathway, so that it's easier to ignore the more blurred aspect and just hone in on the more resolute information that's coming from the unaffected visual pathway. So there are ways that we can measure this clinically, and typically that's done by having the patient put on some filters so that they will see red elements through a green lens, they'll see green elements through a red lens, and then we get them to look at red and green elements. And the patient gives us feedback on what they can see. So if you don't have suppression, and if you're looking through these filters, then what you perceive is both the red and the green elements. And if you're looking at a white light, it will look like a combination of red and green. If you're suppressing, then you'll just report that you're seeing either green, and you would perceive the white light as green, or you might report that you're seeing two lights of the red. So this sort of concept of suppression is really important in amblyopia, and it's kind of like, as I say, it's an adaptation that the visual system is making, so that the unwanted consequences of strabismus and blur are not there and causing confusion. But to get good three-dimensional vision, so if we are wanting to judge the relative position of an object to us, we need to be able to combine the information from our two eyes and decode the relative disparity of objects within space. So this perception of 3D visual space comes in when we get the sensory binocular combination of binocular disparity cues. Now this is lost in amblyopia. So if you have suppression, so if you have ignoring of the information coming along one visual pathway, then you just don't have that opportunity to get that binocular combination of disparity cues, which is what we need to get that perception of where an object is relative to us in space. Now, this is really an important consequence because there's lots of things that we do in the lab to describe the vision of somebody with amblyopia, and we're covering one eye and we're doing lots of tests on their non-preferred eye. But when they leave our lab and go and walk around in the real world, they're doing that with both eyes open. If they've still got pretty good vision in their unaffected eye, well, they can, see the bottom line on an eye chart. They could see, to read pretty well. But what they miss is they miss 3D vision. So impaired stereoscopic depth perception, it's the most common deficit that's actually present in real-world binocular viewing conditions in our patients with amblyopia. And so this is really what's driven a lot of the questions about functional disability in amblyopia. So if you can't see things in depth, can you and can't identify where they are, how does that impact on your ability to do a lot of the fine manual dexterity types of tasks that we do in our everyday life? And this has been the subject of research studies that I've done, and which have been studies, as Krista mentioned, that she's leading the way of globally as well. So this is sort of one of my early studies where we looked at how children with amblyopia perform on a whole range of fine motor skills. So there are some standardized tests of motor skills that are out there to be used clinically, so they can be have age-matched normative data that we can compare the capability of our amblyopic children against, as well as comparing between groups of children who have amblyopia in their sort of visual development versus children who've had normal vision development. So if we look at these, and these sort of battery of tests include things like threading beads on a string, or moving on a pegboard, or picking up objects and placing them or sorting things, and these are timed manual dexterity tasks. So these here, if you're going to get a high score on the task, you need to be completing a number of the activities within a given period of time. And then there are also some visual motor integration types of tasks that we can look at, which are mainly drawing and copying types of skills. So being able to, draw between fine lines or cut out objects. So these ones you get judged on your accuracy rather than upon your time. And when sort of looking at children with amblyopia, they do poorer than children who've had normal vision development on both of these types of activities. There are more children in the amblyopic group that have got clinically below average scores and fewer who perform at the very high level compared to children who've had normal vision development. So we think, well, this is really interesting, and we sort of think, well, that's obviously because they're not seeing in 3D, they're not going to do so well with that, or it's obviously because of their visual acuity. But in fact, when we, whilst there is some associations, and that the reduced vision is related to poorer binocularity and a history of strabismus, the visual acuity deficit itself doesn't tell the whole tale. There are also functional losses, so children with amblyopia read slower than their peers, and that the eye movement dysfunction that's associated with amblyopia, so being slower at initiating the sort of fast eye movements to move along to the next word when you're reading, or fixational instability, are what's sort of being pointed to as the likely causes of slow reading in children with amblyopia. So above and beyond these things that we can measure, what is the overall psychosocial impact of amblyopia? So there have been studies that have surveyed, and generally they're either surveying adults who can describe what their amblyopic experience was and what their fears and concerns are now. And there are also some standardized tests that are able to be surveys of what the child feels about their ability, and also surveys of parents, so that we can find out how the condition or the treatment of the condition impacts on families as well. So what we know from these studies is that there is definitely, in people who are grown-ups with or older children with amblyopia, they very clearly can articulate their concern about their safety of their better eye. So that leads to doubts and anxieties. They talk about the grief and disappointment of neglected treatment in childhood. So if they didn't comply with patching when they were told to, or if they were unidentified early and they were found to have amblyopia later in life, sort of beyond our typical treating window, they talk about feeling really quite sad that they've missed out on that. They describe limitations in driving, reading and mobility, so particularly things like going up and down stairs, and describe trouble with high resolution and low contrast tasks. They also describe the inconvenience of travelling for eye care in search of a cure. And the economic impacts of this condition range from the costs of accessing eye care to feeling that their career choices have been compromised because they've lost some of these visual skills. So particularly depth perception, there are some occupations that are beyond what you can do, or if you've got very poor vision in one eye, you may not qualify for some commercial driving standards, for example. So these patient-recorded outcome measures do describe that amblyopia impacts well beyond the monocular visual decrement that we sort of typically think about, and we've got activity limitation, occupational, emotional, and economic outcomes. And I'd say it's really interesting, and this is studies that both Eileen and I have been involved in, where we use surveys that assess a child's self-perception of their skills in different areas, which sort of build to their self-esteem, and particularly in areas of physical competence or social acceptance, children with amblyopia have lower scores than children who've had normal binocular vision development. So I'll move to now sort of a little bit about some of the current treatments for amblyopia. So the goal of amblyopia treatment is to recover visual acuity and to promote binocularity. So typically we will have as a treatment protocol strategies to remediate the underlying cause, that may be strabismus surgery, or if there's some sort of visual pathway obstruction, it might be cataract surgery. If there's significant refractive error, there will be first step is correcting that underlying refractive error, so wearing glasses for a minimum of 16 to 18 weeks. And then there'll be, if there is still a decrement in visual acuity after those primary steps, then there'll be a program to promote engagement of the amblyopic visual pathway. And that may be by patching or using blurring eye drops. So we'll work through a little bit of those, but just sort of the refractive error correction was something that really, late last century and the early part of this century really became embedded. So I guess previously when a child with amblyopia was diagnosed, that they had the whole gamut sort of thrown at them straight away. So a pair of glasses and a patch right from the outset, and then their visual acuity was monitored. But what was then found when they were recruiting patients for some randomized controlled treatment trials of patching was that if they prescribed glasses for children, had them wear them, and then they sort of brought them back for enrollment in the clinical trial, they found actually there was a significant proportion of the group whose visual acuity had improved in that interim. So just by correcting the underlying refractive error and the child wearing the glasses, these children no longer sort of met the criteria to be in the amblyopia treatment trial. So this sort of then has led to a series of studies that have just looked at, well, how much improvement do we get in amblyopic vision if we first just treat the underlying refractive error. So here we're really prescribing a pair of glasses to promote sensory fusion, and in some cases of strabismus, correcting the underlying refractive error will really promote eye alignment as well. And in young children, so kids aged between 3 and 8 years of life, we were getting a 2.5 row improvement in ability to see on the eye chart, and up to 30% of the group fully resolved just by correcting their underlying refractive error. Now the results aren't as dramatic in our older kids, so children aged between 7 and 12 years, but you still do get improvements in visual acuity, so 2.5 row improvement, and 14% of the group in this study didn't have to go on to have any other type of penalisation treatment. So this is really exciting. If you can just treat amblyopia with a pair of glasses is much less stigmatizing and much less requiring close observation and reinforcement of an active treatment than using patching or any other type of intervention. Okay, so if you still though got a reduction in acuity after correcting the underlying refractive error, well, what's the next stage of treatment? Well, the mainstay that's been around for the last 250 years is putting some sort of an occlusive patch over the better eye, with the principle that that's then allowing this lazy eye to pick up some of the work, and vision improves. Some people, though, don't like wearing a patch. It's obviously cosmetically obvious. It can be ripped off. It can be lost. It can be, a source of frustration and angst within the family. So an alternative is to put in a drop of atropine into the dominant eye. Now, atropine blocks the parasympathetic innervation of the ciliary muscle, which is the muscle that helps us to adjust our focus. So you will get blurred vision, particularly for near tasks. And if a child is also a bit long-sighted in this eye and aren't wearing a corrected lens, and plus we've added the atropine, then they'll have quite blurred vision in that eye. So it's blurring out that visual pathway to allow the impeded visual pathway to kickstart in its development. An alternative to that is putting on a frosting filter over a pair of glasses. So these types of interventions are there, but they do have negative unwanted side effects. So with patching, we've got the social implications of and stigmatisation of wearing a patch out in the real world, family trauma with uncooperative kids taking the patch off, so not fully adhering to the treatment regime. It might be dangerous for a child to be in the playground with only poor vision in their amblyopic eye, or they may not have really good enough vision in this eye to do well in the reading and technology demands of a classroom. And in very young children, there's actually the risk of iatrogenic amblyopia, where if you are putting a patch over the better eye for prolonged periods of time, you might actually impede that pathway's visual development. So there were sort of negative consequences of patching. So there have been some randomized controlled trials that have then compared patching with atropine head to head. And what was really found was that atropine did come out as effective as patching for treating amblyopia. It was a little bit better accepted by families and children, and the effect was sustained as well for up to 2 years. So do these treatments work? Well, they do, and in a significant proportion of children, they work well. So if we compared, looked at children aged 3 to 8 years with moderate amblyopia, if you either patch them for somewhere between 2 and 12 hours per day, we're getting about a 2.5 row improvement of acuity. Or if you use atropine drops either daily or weekend, again, you get about a 2.5 row improvement in acuity. And in young children with severe amblyopia, so quite a significant loss of vision, they can get up to 4 to 5 lines improvement in vision. So these treatment regimes do work. In older children, the treatment effect is not as impressive, but you will still get between 1 to 2 rows improvement with both moderate and severe amblyopia, even with your patching or using the blurring eye drops. So whilst we do get impressive improvements, many don't fully recover. So somewhere between 15 and 50% do not fully recover. Often the binocular deficit will persist, and 25% of the group will actually regress. So if you followed these children after treatment and had a look to see how long your treatment effect was sustained, there was about 25% will regress. And in older children and adults, we just don't get good outcomes with either patching or atropine. So the disadvantages of these current treatments, as well as sort of their, lack of dramatic effect, is that we do have a long time course and variable compliance. So with patching, we may be talking about children having to put the patch on for 2 to 6 hours a day for at least 6 months, but in some cases they're patched for several years. And our compliance rates, when you actually measure it, is only about 50%. So this is really now leading to a call for new treatments that will promote vision development in a shorter time frame, that will treat older children and adults, that will treat the binocular sensory deficit as well as that monocular vision loss, and hopefully also treat the recalcitrant amblyopes, the ones that just don't seem to be getting better by our traditional means. So we have these novel and emerging treatments. So these treatments really are targeting, some of them, that binocular dysfunction that we think underlies functional capability, but also might be a gatekeeper to some of the improvement in visual acuity. And they also hope to engage higher order visual processing. And maybe there's something in that could be the extra source to help the treatment effect happening. So our goals of these new treatments are that we have effective, faster treatments, that they will have a duration of effect, that they'll be able to treat older patients and hopefully be less onerous on patient and family. So what are some of these new treatments? Now, so a lot of these new novel treatments have been trialled in the lab in adults, and which are the group that traditionally we've not been able to have good effects with. And then the next step from that is then taking them from the lab and delivering them into being home therapy for children. But we'll start with some action video games, because I think this was super cool. They had adults with amblyopia play Call of Duty or Medal of Honor, sort of Pacific Assault for long periods of time, or they had them playing Sim City, which is sort of, I guess, less sort of engaging and violent, but also was a sort of a video game, and had a look to see, even though this was being done as a monocular therapy, so a patch put over the better eye while they were playing these games, they found that in adults, where they thought they wouldn't get improvement, they were actually getting quite measurable improvements in visual acuity. Now, they kind of looked at these because there is evidence in the normal visual system that playing computer games can in fact enhance our visual capability. So it seems to induce some neuroplasticity and improve visual attention. And so with this, then you had flow down improvements in visual acuity. So the question is whether or not it was reducing some of the noise in our neuro interpretation, and that we might have increased sampling efficiency, and that might help with some of that crowding phenomenon that I described earlier. So we get improvements in visual acuity, improvements in positional acuity, spatial attention, and 54% had improved stereopsis with this monocular therapy. So that's interesting. We also talk about perceptual learning, where here you have improved performance on a sensory task by repeated practice. So, you know, the types of tasks that people were doing might be identifying the orientation of sinusoidal wavings, or sometimes they were repeated sort of vernier alignment type tasks. And what is found, I guess, unsurprisingly, is that you do have some improved performance on that particular task, but also you had transfer to improvements in other areas of vision. So in fact, you did get improvements in visual acuity and stereo acuity, even though these were monocular types of activities. So the question is whether or not these sorts of things are also inducing plasticity in the visual system, and whether there might be reductions in that neural noise or retuning of the relative binocular input, so that higher level rule-based cognitive learning process. So if we think sort of beyond our eye to visual cortex, but maybe from visual cortex across to other areas of neurophysiology that are responsible for, you know, attention, engagement, maybe there's something in this. Now, binocular activities aren't necessarily completely new. Now, and if there's anybody in the audience that, you know, in the 60s, 70s or 80s had amblyopia, they might remember going to you know, an orthoptist and spending time looking into a synoptophore, which was an instrument that allowed presentation of different types of images to each eye. So you would sort of sit with your chin on the chin rest. An image is portrayed along one optical pathway and along the other, and then they were lined up, and they might move where the elements were or change the brightness of an element. There are also some vision therapy kind of activities that I was trained in the 80s, where we would have people look through red and green filters at objects through their red and green glasses and try to engage that binocular vision. So there were active training procedures to try to break down suppression and build that sensory motor fusion. Now, they could be home-based but boring, or office-based and inconvenient, and how well you did tend to depend on the maturity and the cognitive ability of a child, and patient compliance and adherence to treatment. But with these, there is also a lack of randomized controlled treatment trials to test their efficacy. So it's out there, but I guess it's not really fully recognized as treatment. So then we come to some of these binoculardicoptic activities that is really a mainstay of some of the new treatments. So the principle here is that if you can vary the contrast of the information that's presented to the dominant eye, you might actually hit a tipping point where that amblyopic eye will in fact engage. So if you've got elements presented to the amblyopic eye and the fellow eye at full contrast, then the information seen by the fellow eye is what's perceived. If you slowly damp down the contrast of the information presented to the dominant eye, you will reach a tipping point where the amblyopic's eye perception will come through. So this sort of idea of then balancing contrast developments between the two eyes and then presenting them as game-based activities is one of the really exciting areas in the areas of clinical trials that I've been working with Krista and Eileen. So the original trials of this were sort of looking at falling block games, so Tetris games, and certainly in the lab we were showing improvements in acuity, and home-based is not necessarily coming through as yet. This has also been, then perhaps this is a little bit boring and challenging for younger kids, put into different types of games where the different elements are presented to both eyes at the contrast level, which will engage both. And also there are some passive video cartoon watching where, again, you'll only see the entire cartoon view if your visual system is attending to the information that's coming from both eyes. So with these novel and emerging treatments, there are all showing some improvement in vision. So there is a meta-analysis that's looked at that. And, you know, really, if we look across a number of studies that have looked at dicoptic treatment, studies that have looked at perceptual learning, studies that have looked at video games, you know, overall, we do get an improvement in adults of about 1 to 1.5 lines. So there's certainly something there. And I think it's interesting that none of them is really stepping out more than one or the other. But I guess the question that you might have is then, if you treat with these kinds of things, do you actually get a flow through improvement in function? And this was a question that we did a study of, where we actually employed this binocular treatment in children with amblyopia. And we measured their fine motor skills performance both before and after treatment. And so we took children with amblyopia and measured their fine motor skills at baseline, and similarly measured their fine motor skills of children with normal vision development, and we found that there was a difference between them. We had the children do 5 weeks of amblyopia binocular treatment, and what we found was that their fine motor skills did significantly improve, and in fact they improved to the level of their control children. Now, we did do a retest in the control children as well at 5 weeks, just to make sure that any improvements wasn't just from a bit of a practice effect, and in the control children there was no change. We also then followed the children up after 12 weeks after their treatment finished to see whether or not this improvement was retained, and in fact it was, so that fine motor skills improvement was sustained for 12 weeks after treatment. So what was driving that? Well, we did find that there was a bit of improvement in visual acuity, and that the improvement in acuity was better than test-retest in children. And for 6 kids, there was actually quite a significant improvement in amblyopic eye acuity. We also looked to see whether there was improvement in their binocular function, so whether there was a change in whether children suppressed or a change in their level of stereopsis. And what we did find is that there was an improvement, and we had 8 patients improved a level in their binocular function. Pre-treatment, 6 of the children were suppressing under sort of habitual binocular viewing, and post-treatment only 1 was still improving. So our conclusion from this study was that fine motor skills improve, but the improvements really weren't fully explained by improvements in acuity or binocular function. So our problem here is that the relative contribution of visual resolution and binocular function and eye movement control and accommodation and stability of eye movements to functional task performance is still not fully known. So a question is that whether or not there could be some higher order processing deficits, so some downstream effects, could that possibly better explain the poorer functional effects in amblyopia? So we know that adults with amblyopia show deficits in some complex visual decisions, and that does suggest a higher order downstream effect. But these sorts of things hadn't previously been looked at in children. So that was sort of the subject of a recent study that I conducted where we looked at visual search and attention in children with and without amblyopia. So we used some standardized tests again that look at how well you can attend to information in your visual field and make some critical decisions. Now, with these tests, they are high resolution tests, so they're well within the visual capability of the visual system. They're tests that were conducted with both eyes open, so they shouldn't be limited by visual acuity. And they're tests that don't require high level depth appreciation, so they shouldn't be impeded by the poor depth perception. So the two tests that we used, the first one was useful field of view, which is a test of visual attention and processing speed. So these are computer-based tasks, and really what we're looking at is the minimum presentation time required to make a correct judgment. So in the first part, there flashes up either a car or a truck, and the child is required to give the responses to what they saw. So it's how long that is presented on the screen that varies from test to test. The second one is divided attention, so they need to identify the peripheral object, and in the third one they're required to identify the peripheral object but in the presence of flankers. So these are processing speed types of tasks. And the second task that we had the children do was to do a visual search and scanning task. So here, the trail making test, and we did this as a computer-based activity where they're required to link a series of numbers or digits and connect the series in the right order. So they had to find number 1 on the screen and then connect it with their mouse to number 2 and then connect it to number 3 and ongoing. Or with the test B, they had to get a sequence that went from number to letter to number to letter. And there was a dynamic and a static presentation. So with the static presentation, the digits or letters didn't move between their responses. With the dynamic one, it did, they scrambled. So we have increasing complexity of the task as they go through. So what do we find? Well, we found that amblyopes did have slower visual processing speed on both the divided attention and on the selective attention tasks. And the differences between the amblyopic group, so the time that they needed to make a correct response increased, and the difference between the amblyopes and the controls grew as the tasks became more complex. With the trail making test, again, we found that the children with amblyopia took significantly longer than the controls to complete the task, and that was the case when it was both a static and a dynamic presentation, but the differences between the groups really did grow as the complexity of the task increased. So what we found was that visual acuity and binocular function, though, weren't significant predictors of the performance on these tasks in the amblyopic group when we adjusted for that. So again, we've got higher order visual processing deficits in these children that's not related to visual acuity and binocular function. So perhaps some of these higher order processing aspects are also contributing to poorer functional performance. So in summary, we found that amblyopic children show reduced performance on visual attention and visual search and scanning tasks. And we do need to explore the implication of these executive function impairments on fine motor skills and reading and whether or not these functions improve with treatment. So there are some questions for future study. So this is sort of throwing it out there for Krista and Eileen and the amazing group at the Retina Foundation. So the questions I think that lie there are, could higher order visual order executive function deficits underlie the performance measure decrements that we've observed in children? Could the success that we see in older children and adults with emerging active amblyopia treatment in fact be due to how they engage in the higher order visual attention processing of these new and novel treatments? And if we treat amblyopia with methods that target that executive function with engagement, do we get better outcomes and better improvements in functional performance? So I appreciate I have gone a little long and I do apologise for that. I'd like to thank you for your attention and I'd like to introduce you to my wonderful family and send you greetings from Australia. So thank you for your attention.
Thank you, Dr. Weber. And if there are any questions, I would welcome you to put them in the chat, or you are welcome to unmute yourself. In the interest of time, we'll take a few questions, but if there are any additional, you are welcome to email directly to me, and we will reach out to Dr. Weber and have her provide an answer. Dr. Kelly?
Okay, so I'll wait for some questions, but before any questions pop up, I will ask a question for you. So whenever we talk about amblyopia, we usually focus a lot on children, and because it's a pediatric eye condition, you treat them when they're children. And I know a lot of people do research on how it impacts adults, but I think I'd like for you to give a little overview, I guess, or just let people know how this eye condition can still impact you throughout your whole entire life, and what kind of things that people would see with that.
Yeah, I think probably some of the patient-reported outcome measures studies are really pointing to that. That in adults they still describe that they have difficulty with driving, difficulty with some of the high-resolution motor tasks. So, threading beads, pouring water. If you were going to pour water into a cup, or misjudge where things land if you're putting objects down. As I mentioned, if you don't identify this condition early, if you don't treat within the window, then that vision loss can be lifelong. So if you have got, for a commercial driver's license, you would need to have acuity of 618 here. What's the conversion? Is that 660, 680 to be able to qualify for a commercial driver's license. So there are some occupations that are beyond you. That there's those things, and then people really describe that the vision looks flat because you don't have depth perception, and if you do try to look with your better eye, you just don't see well. We also know that there's a lifetime risk of visual impairment. So if you have an accident as an adult and lose your dominant eye, then you just don't have a good spare to go on with. And that sometimes guides our treatment goal, where if we can at least get that in affected eye to 612 or 2040, which is the minimum you need for a driving standard, so that if you did have an accident, lose your better eye later in life, that you can still meet those vocational standards.
I was on mute. Sorry, I think the chat was disabled. It is enabled now if somebody had questions. But Kate Connolly has a question. She has her hand raised if you wanted to come on and ask a question.
Sure, thank you. And thank you for your talk so far. It was great. So my question is, we've noticed through some of the randomized clinical trials, in particular through PDIG, that though we have a good concept with that dicoptic imaging, we haven't really seen success in the randomized clinical trials. Can you maybe shed some light on why you think that's happening? Do you think it's the fact that we're designing the treatment trials, in a one size fits all in terms of how we're altering the contrast of the fellow eye? Is there something maybe that we're missing that is holding us back in how we're designing these games to hopefully have success?
Yeah, I think that's a really good question, Katie. I think there is something in the engagement space. So one of our problems with games and the breadth of the age group that we're running the treatment trials in is the age group's quite broad. So if you have a game that is sort of set to the capability of the middle of the group, then it might be too boring for an older child in that group to engage with. Or it may be too difficult for the very youngest ones in that group to engage with. So their actual adherence to the activity might not be there. Now, I know with the randomized controlled trials that there have been methods to monitor adherence, but I think there's a difference between monitoring adherence and somebody actually being really engaged in the activity itself. So there may be some of that. So when we're talking about sort of setting the contrast level, I think that from my experience, they'll start off with perhaps 20% contrast, so very, downgraded visibility to the dominant eye, and then slowly ramp up that contrast until it is equal, until suppression is broken. And they are definitely targeting getting rid of that sort of suppression element. And that seems to be successful. So I think the breakdown of suppression is happening, but I think that maybe it's more in the engagement of the games. Now, as you probably know, there are also some trials that have looked at virtual reality headsets for presenting all sorts of different types of games, and that in itself has got some problems in that the headsets don't fit the very younger children, and again, the games that have been in some of the trials there aren't necessarily engaging, so kids are getting sick of doing the treatment and not wanting to do it.
Thank you. And I think we have time for one more question. Stephen Dakin.
Hi, Anne, that was a nice talk. Greetings from across the ditch,
Hey,
New
Steve.
Zealand. So this is kind of a follow-on question to that. I think you're absolutely right about engagement. So certainly Bravo, the study you alluded to, which was run partly in New Zealand as well. The issue was coming up with digital, with a game that engaged children equally well. Children are very discerning consumers of digital content. And it's my belief that that's why I think there's something more to movies, because movies, you rely on somebody else making the content for you, which I guess comes to my question, which is, do you know of any evidence that actually suggests any of these digital treatments, including our own, I should add, are any better because of anything other than improved compliance? Because compliance is so poor with patching.
So I'm not sure that I fully get what your question is. So compliance with patching is poor because they may do 2 hours when you've prescribed 4 hours, and
Right.
yeah. So I mean, I think
the digital treatment studies that have done well have typically engaged higher levels of compliance, and that's hard to do in a randomized trial, for example.
Yeah. So how do you actually foster compliance in children when you're getting them to do these games? Is that what you're asking me?
I'm just asking if you know of any evidence that the superior performance of digital treatments is anything other than just better compliance. If you could get kids to patch with 90% compliance, do we actually have any evidence that that wouldn't just produce the same outcomes? That's all.
Yeah. Well, I think there's been recently a study that's looked back from the Bravo, because you were monitoring adherence to treatment, and that the improvements didn't necessarily seem to be linked directly to compliance hours played. But I think the challenge is that you might have recorded time that somebody is using the device, but you're not actually measuring what proportion of that time they were truly engaged in the activity. Now, one of the things with patching, and if you just said, look, you can patch and do whatever you want to do, so you can play your favorite Minecraft, or you can read your whatever book, well, then maybe that's going to be more engaging for them, and it might be as impactful, but that is then not addressing the underlying binocular dysfunction. So I think that is the true challenge, is as you've described, finding the types of really engaging activities, but then trying to also have these extra elements that we know that appear to be important, of breaking down suppression to drive improvements in stereopsis.
Okay, I think that might be it for questions. I think Amy has a couple more little things. Great chat, great talk.
Thank you, Dr. Weber, again for your time. And we just would like to share a story this evening of a patient that has been served by the Retina Foundation, but to speak to your research that you are doing, not only in Australia, at the Retina Foundation and around the world, how that's impacting patients like Kate.
This is Kate, take one. My name is Kate Lockwood, and I was diagnosed with a lazy eye. They started giving me patches and helping me get stronger and finding out what type of glasses will be the most helpful. I feel like it is cool and interesting that we got to try these tests. It's so cool how it can be like a fun video game, but also help your eye get stronger and healthier. I feel like they really help you understand what you're going to do, and they make you feel comfortable and so you don't have to be scared. I think they care about Kate as a whole and what best would help my eye get stronger. And now, we found out today that I don't need glasses anymore and that I might just be okay without them because my eye got so strong and improved so much. Thank you, Retina Foundation.
So it's patients like Kate that bring us to the Retina Foundation every day to support the amazing and innovative cutting-edge research being done for pediatric eye conditions, inherited eye diseases, and age-related macular degeneration. We would love for you all to get involved with the Retina Foundation, and there are several ways to do that. One is attending our next Keeping an Eye on Innovation lecture coming up on Tuesday, October 19th at 7 p.m. by Dr. Michelle Pardue from the Georgia Institute of Technology and Emory University. Additionally, you can connect with us on social media. We are on all of the social media handles listed here, where you can learn more about patients just like Kate. And lastly, as I mentioned at the beginning, we would graciously like your support for the Retina Foundation as well. We couldn't do the work and the scientists and the researchers at the Retina Foundation without the support of individuals, corporations, and foundations. And as I mentioned at the beginning, if you would like to participate today in our Day of Giving, here's that QR code again that you are welcome to just use your phone and scan the code here and participate with the foundation by supporting our amazing research. So thank you, Dr. Weber, again. We appreciate you joining us for Australia, and we look forward to seeing everyone again in October. Have a good evening.